this subject. I think Jeff brings up a great point about the goals of surgery. And in spine surgery, it's to decompress the neural elements and provide stability in certain circumstances and for certain patients. And I think one of the things that I'm going to touch on is a lot of the decisions and the things that we do before we get to the operating room make a whole lot more difference than a lot of stuff that we do in the operating room, meaning getting the patient ready for surgery, talking with them. I mean, I think as a spine surgeon, we're forced to be the most multidisciplinary practice because you really need to work together with your physiatry group, your physical therapist, to make sure that you're helping the people and you're actually helping the right people. So with that, I'll be talking about minimally invasive spine surgery at Northwell. I'll be talking about the MIS spine group that we have here, some of the work that we're doing, and then I'll dive into the technology that's really driving MIS surgery. And MIS surgery is basically what Jeff said. We're trying to limit the amount of soft tissue dissection that we do to hopefully help people recover better and quicker, while still doing the things that we need to do as spine surgeons, mainly to decompress the neural elements and at times provide stability and effusion. I want to make a plug for the MIS working group. We meet every 6 weeks. We have a group of all-star surgeons in our consortium. We talk about research initiatives, education, and marketing. Our first annual meeting to teach residents and fellows in regards to MIS techniques was this past fall, very well attended, and we're always welcoming new members. We had a great showing at the Society of Minimally Invasive Spine Surgery this past fall. It's an annual conference in Las Vegas, so spine surgeons know how to pick their conference locations, but we were well represented, and we had a lot of podiums and posters and medical students and residents presenting for us, and you know, we're gonna keep on kind of driving the ball forward in terms of spine surgery and innovations. And along that, I think it's also very important for, you know, this forum as an opportunity. There's education among attendings that needs to happen as well. I think this is a constantly, that's why it's called the practice of medicine. You're always supposed to be practicing, you're always supposed to be learning, and I'm a big believer in learning amongst all the surgeons we have at Northwell. So we're creating a platform for attendings to work with each other to do new and innovative procedures. I've placed a couple pictures of an endoscopic foraminotomy that I did at North Shore recently, and I myself have visited Lenox Hospital to observe interlaminar endoscopic procedures because we always need to keep up to date as a community of surgeons. So where are we going in MIS surgery? I think you can't do an MIS talk without talking about endoscopic spine surgery. Again, this is using ultra minimally invasive techniques to make approximately a 1/4 inch incision to be able to get to the neural elements, to insert a camera near these nerves and nerve roots to perform a decompression and infusion procedure. This is quote unquote a hot topic in spine surgery these days. You're really moving from an open procedure where people have done well and they will do well, and I'll talk about that a little bit more, to these uniportal or biportal procedures where you're basically using smaller incisions with less muscle dissection to accomplish the same goals. Here's a couple pictures of me doing a biportal endoscopic procedure at North Shore. And as I mentioned, there's really been an explosion in interest in this in terms of the amount of publications at NASS, or North American Spine Society, this past year. There was a huge sort of presentation in regards to endoscopic techniques, and a lot of companies and a lot of industries are trying to push into this space. But to speak to Jeff's point, I think it's, are we chasing after percentages with these cases? People have done very, very well with a properly indicated lumbar decompression procedure with that green tray on the left. And that's all the equipment you need to do a well-done decompression procedure versus the huge capital investment. We're talking like $500,000 for some of these towers and these instrumentations to do something where you still need to do the decompression portion of the procedure. And we have data that shows the green tray works just fine. So it's up to us as MIS surgeons to prove to you all as a community of people taking care of patients that we're actually driving the ball forward. But there's been a groundswell of interest from surgeons. It means there will be more to come on this, more innovations in this space. But this is always a good thing to keep in mind as we push the ball forward in spine surgeries. Are we really helping people? Are we really just innovating for innovation's sake, or are we actually driving health-related outcomes? That's where I do think there is a role of potentially moving endoscopic spine surgery in the fusion space. Getting to the disc space can be more reproducible and safer using some endoscopic techniques for the properly indicated patients. This is utilizing Kambin's triangle, which is an anatomical location between the thecal sac or the nerve root centrally and an exiting nerve root to get to the disc space. The challenges are obviously, in order to create a fusion, you have to build bone between the vertebral disc space. That means you have to take out a lot of disc. You got to do an adequate discectomy. You got to ensure there's a safe corridor for your instrumentation. And you can't just put a small piece of metal. You got to be able to put in an implant that provides actual biomechanical stability. But, you know, there's a lot of really, really smart PhDs working on this problem, and there's likely going to be more in this space over the next 5 to 10 to 15 years. All right, robots are going to be everywhere. No, but I actually think robots in spine surgery, I have some very sort of maybe hot takes on it, but I'm not sure it's really driving the ball forward as much as some people might think. I do think that there are multiple studies out there that do show improved accuracy in screw placement, but there can be some questions in regards to methodology for this. It's also a large capital investment for hospitals, but it is something that a lot of people are talking about and a lot of people are doing. And if in the right hands, it can be a big help for patient care. For me, when I was tasked with this task about where are we going in spine surgery, and I was thinking through how robots could help, I think if the real innovation is if I can be having a cup of coffee in the surgeon's lounge while the robot's doing a surgery, but we're not there yet, unfortunately. The real innovation will be in assistance in decompression procedures, and there's a lot of articles from China that show, a robot doing a portion of the hemilaminotomy. But even if we get a portion of our surgery done where we take the bone out, you still have to take some very difficult bites with a caris and rongeur for the ligamentum flavum. You have to retract the thecal space in tight spaces. At this point, this is really science fiction, but I do think this is something that, maybe 50 years ago, people were looking at their, thinking about a cell phone that you carried around that you could talk to anybody around the world, and that seemed like science fiction. So maybe we are heading this way. Clearly, there's more to come. Artificial intelligence in spine surgery is also a very important topic. I think, to speak to the point that I was making before, so many decisions about how a patient does after spine surgery is done before they come into the operating room. If you ask 10 different spine surgeons what their opinion on the case is, you're going to get 20 different opinions. And I think that is where AI can really make a huge difference, because you feed in clinical data, like how a patient's clinical exam is, the amount of stenosis they have on an MRI. And if you can use a massive database of previous patients with similar sort of patient profiles, maybe you can spit out something that says, listen, this person probably needs another 6 weeks of physical therapy. Listen, this person probably needs an epidural. Or, you know what, this patient probably should just end up getting the surgery quicker. And those kind of decisions could be assisted by AI, or AI is just another sort of way of analyze a computer that's able to run a massive amount of algorithms to help our clinical decision making. And so this is something that I think is super interesting and super important for us as spine surgeons as well. To that effect, there's been a tremendous amount of innovation in terms of patient-specific instrumentation. There's been a lot of companies out there analyzing sort of CT scans, MRIs, before a person comes to the operating room to plan for the screws that they would need, the interbodies that they would need, et cetera. And so how does that help us? If you have a patient-specific instrumentation, I think it helps us by making the overall surgery more efficient. If you know the type of screws you're going to use, if you know the type of interbody you're going to use, you can open less trays. And that can be a dramatic amount of reduction in terms of the amount the hospital is paying for a surgery, and help with some of the turnover in the operating room, which is important because nowadays there's been a tremendous drive for spine surgery to be done in ambulatory surgery centers. I have patients who have come to me and asked me, listen, can I have my surgery done at Schwartz instead of going to North Shore itself? Meaning, can I have my surgery done at a smaller facility where my grandma can have their microdiscectomy and leave that same day? So there has been a push towards doing more spine surgeries in ambulatory surgery centers, and I think this couples really well with MIS procedures for several reasons. First and foremost is less muscle dissection. I personally don't put drains in for my surgeries, so that leverages the smaller incisions and reduce initial pain profile, and that can help people get out of the hospital or get out of the ASC quicker. And there's been a huge rise in literature about this as well. At North Shore, where I practice, we're already making this transition. There's a few specific things that I do for my patients. I always try to get them to do pre-op hydration prior to surgery to try to help them get sort of less nausea after the surgery, more energy after the surgery so they can ambulate. I was at grand rounds for anesthesia in regards to erector spinae blocks. This is where we put local anesthetic prior to beginning the surgery to hopefully help people reduce their pain postoperatively. I think this is a no-brainer. It takes about 10 to 15 minutes. Anecdotally, from my patients, they've done better in terms of their postoperative pain, and I use them for all my lumbar spine surgeries. I really work well with the physical therapists at North Shore because they're right on board in terms of early ambulation and getting people up on post-op day 0, which is super important for me. And like I mentioned, I avoid drains, and I do push the envelope in terms of NSAIDs and steroid to avoid narcotics, but there's no free lunch with all these medications, so it comes with its own complication profile. But I do think avoiding narcotics can be helpful. All right. For my last 2.5 minutes, I'm also going to talk about muscle health. Muscle health is something I'm very passionate about. I think if you drink the Kool-Aid of MIS surgery or minimally invasive spine surgery, you're basically buying into the fact that less muscle dissection, less injury to the multifidus and erector spinae will help people recover better. And there has been extensive literature that I've been lucky enough to be a part of that shows the impact of muscle health and outcomes before and after surgery. And we're actively doing this type of research at NORTHWELL. We're doing a muscle biopsy study. I think I did my 18th patient with the help of Dr. Grande in terms of biopsying muscle during surgery to see what kind of pathophysiologic immunohistochemical changes happen in the muscle that may impact a patient's outcome after surgery or before surgery. We're determining the association of muscle health on spinal alignment and motion. If people have a stiff arthritic back, what happens to their multifidus muscles? Does the multifidus muscle contribute to the low back pain that some of our elderly folks are dealing with? These are all things that are sort of the innovations that I'm interested in talking about in terms of MI surgery. And teasing out how MRI-based muscle health parameters can impact patient-reported outcomes is super important. I'm working along with some of my other colleagues at Northwell on studying how we can work with industry to study interventions that could impact muscle health, such as the mainstay reactivate implant to stimulate the multifidus and hopefully help people's back pain postoperatively. So with that, thank you very much. This is a topic I could talk about all day. So
Wait, one question. Can multi-level fusions be performed through an MIS approach?
That's a great question. For me, anything over 3 levels, and this is my personal statement, and there's surgeons across the country that disagree with this. If you're doing more than 3 levels, the physiologic impact of that surgery, it's a wash between MIS and open. I think that people that sell MIS deformity surgery, that might be good for 2 or 3 surgeons across the country that can do 4 or 5 laterals like that. But for 90% of the surgeons, that's like a 6-hour, 7-hour surgery. And 7 hours under anesthesia, that's not MIS, in my opinion.
Besides the length of surgery or the number of levels, are there any other, say, physiologic components, levels or degree of stenosis that you would say this is not an MIS candidate?
For 1 or 2 levels, personally, I don't think so. I think you can do a lot through a tube, but you have to be honest with yourself that it's going to take longer and you're going to have to do more work. And you're going to have to counsel the patient that you might be under anesthesia for a little bit longer. And I tell people that. I say, like, I'm going to be using X-ray, sometimes CT scan. I'm going to be, I'm not going to be making a big incision where I can see everything. I'm going to be working through a tube that's 15 to 20 millimeters in size to do my work. This might take longer, but I think that the less muscle dissection in the long run will help you.
Very Thank you so much. That was great.